I just wanted to now move on in the programme to introduce Professor Ruth Gilbert. Ruth might be known to many of you. She's a clinically qualified paediatrician who's trained in epidemiology. She's based here at the Institute of Child Health, and her research programme focuses on child maltreatment and the contribution of healthcare to the recognition and response of child maltreatment. I know Ruth is very passionate about this area, and in particular the use of data to help us in our work. So I'll hand over to you now, Ruth. Thank you.
I'm going to talk today about child maltreatment broadly, which includes abuse, physical, emotional and sexual abuse, and neglect. So I see all of those forms as part of child maltreatment. As Jenny says, I'm going to be reporting mainly about what we can tell from administrative data sets, mostly in the healthcare sector. So most of my talk will be related to that sort of data and what it tells us. I'm going to deal with sort of 4 areas where different approaches to measuring child maltreatment tell us something about the contribution of health services. First of all, I'm going to talk about how, through looking at data from multiple agencies, health and child protection services across countries, we can put the contribution of healthcare into perspective. Secondly, I'll show how we need to use data within health services to take a population perspective rather than just an individual child perspective. Thirdly, I'm going to give some examples of how we need to recognise the change in presentations of child maltreatment and its consequences across the life course, and how those individuals present to services, particularly as they get older. And fourthly, I'm going to take a look at how we can look at health services for the whole family, and how through those we might be dealing with some of the problems both in parents and the children to take a therapeutic approach. So the first part is based on the 6-country comparison of child maltreatment indices that's in your pack that was published in The Lancet last year. And here are the 6 countries, well, 2 of them are states actually: New Zealand, Western Australia, Sweden, England, Manitoba and the United States. These were chosen because some of the smaller countries are very, very good in terms of the amount of data they have. So I'm not going to dwell on the main point of that study, which was to look at trends. You can read the paper in your pack. I'm just going to draw out a couple of messages about putting healthcare into perspective. And I find this pyramid particularly useful to think about what data we can get at that's routinely collected administrative data and is consistently collected over time and similarly collected in different countries, different states. So at the top we have vital statistics, so death registrations for violent deaths. Then we have variable amounts of data from child protection services, different indices from out-of-home care down to notifications. And we have a whole spectrum of health data, some of which you're going to see during the talk today. In this analysis, we just focused on an indicator called maltreatment-related injury admissions. So these are injury admissions where in the International Classification of Diseases codes, in these hospital discharge data, indicate either concerns about maltreatment or assault or indeterminate cause of the injury, or concerns about the child's immediate family environment, such as problems with primary caregiver. Because we were just looking at children aged 10 or under, we made the assumption that maltreatment-related injuries, or injuries that had these codes in the data, were in some way likely to be related to either abuse or neglect. and probably very many of them were related to neglect. And I base that statement on the National Canadian Incidence Study, where Nico Trocmé went through all children that had substantiated child maltreatment, so it's about 7,000 cases there, and looked at those that had injuries requiring medical attention. And half of those injuries requiring medical attention were due to neglect. So we expect a lot of these injuries to be due to neglect. Okay, and at the bottom of my pyramid, I always want to make the point that here we're just reflecting children that come into contact with services where the problem is recognised, recorded in clinical records, and coded in discharge records. If we really want to know about occurrence, then we need to be looking at self-report and parent report studies that measure actual occurrence, much of which does not come to the attention of any services, let alone come to the attention of child protection services. I'm sure that's a message that you're all well aware of. Now, just to give you some ideas about numbers, here I've just put in some numbers for infants, so just children in the first year of life, and these are taken from 2006. It was all calculated for that year because we could do it for all 6 countries in that year. So what you see from this is a lot of notifications. This is estimated as for England, around 35,000. And a lot of child protection plans and children placed in out-of-home care. Violent deaths are a tiny proportion of this problem. Maltreatment-related injuries are a relatively small proportion, only 500. That doesn't surprise me. I know that injury, when you go to multidisciplinary team meetings, in hospital teams and so on, you will know that injuries are a very small proportion of concerns about child maltreatment. More on that later. So in terms of putting this in perspective, the one thing is that here we're dealing with the tip of the iceberg. The second thing that was very useful for putting child health services in perspective with other services was in Western Australia, we were able to link data between all services. And what that showed was that of those that died of violent death, only 1 in 5 had ever been notified to child protection services. And of those notified to child protection services, only 3%, so emphasising injuries being a small problem, had ever been admitted for a maltreatment-related injury by the time they were 10, so before or after their notification to child protection services. But around 2/3 of those with a maltreatment-related injury admission had at some time, by the age of 10, been notified to child protection services. The point here is this is a jigsaw of services that see these children, and to understand who's coming to attention and what is happening to them, we need to look at the multiple services. Okay, so summarise the messages from that example. Firstly, violent deaths and maltreatment-related injuries are really the tip of the iceberg. They're small, so management of these and how they appear in the data is really small relative to other agencies, and in this case to child protection agencies. But what we did see across these 6 countries was relatively similar rates, only less than 2-fold variation across those 6 countries, except for the USA, where they have a 5-fold higher rate of violent deaths in children compared to the other countries. And they have unusually low rates of maltreatment-related injury admissions, which I think is related to poor access to care. But otherwise, it was looking like our indices were performing relatively similarly across countries. In contrast, there were 2 to 10-fold variations in the indices for child protection agencies, so much more variable and probably reflecting much more in terms of policy drivers and service configuration than the need or occurrence of problems. My second example then is to show to you how important it is to take a population perspective, even just within health services. And this is based on data that we published last year. This is using, again, maltreatment-related hospital admissions for the whole of England. And here we just looked at children under 5 years old, and we pulled out those children that had ever had any head injury admission or a fracture admission. And we grouped them by by intracranial injury, so you'll know that those are very strong markers of child maltreatment, long bone fractures, and then this group without any head injury, without any intracranial injury or without fracture. And what you see is what would be expected along the side here. We've got the percentage of these admissions that had any of our maltreatment-related codes in them, so a flag for concern. And as you'd expect, for intracranial injury for children under 6 months, then it was very common, so 31% of them had a maltreatment-related injury code. And that got less for children 6 to 12 months and even lower for the 1 to 5-year-olds. And similarly for the long bone fractures in children under 6 months. So this is probably under recording because we're not there's loss at each stage from the clinician recognising a problem, the clinician writing it in the notes, and the coder coding what is written in the notes. There's losses at all stages. So we'll be underrepresenting them here. But certainly for this group of just head injuries that weren't complicated by intracranial injury or fracture, then the rates were low. This is the clinical perspective, the risk for the individual child with intracranial injury of there being a maltreatment-related concern, the clinician's perspective about that child in front of them. Let's turn it round now and take the population perspective. This now shows you the proportion of all children who had maltreatment-related concerns in the under 5 group. Where were they? And what you can see was that most of them, or very many of them, in fact half of them, were in the group aged 1 to 5 years. So protocols that say that any injury in children under 1 should be seen by the child protection team or the named nurse, named doctor, will be missing half the cases. And again, half of them, or more than half of them, about 2/3 of them, were occurring not in the high-risk children with intracranial injury or fracture, but in the low-risk children with uncomplicated head injury. This is what all of you know, that high risk in rare cases will contribute less to the problem than low risk in cases that are common. But this is an important message to remember for planning services, and particularly for writing guidelines, in that you don't want to concentrate your responses just to the rare high-risk cases. Moving on to the third point then, how do presentations of child maltreatment change over the child life course? And to start off with, I'm just going to look a little bit at definitions here. So as you know, child maltreatment is the harm or risk of harm to a child caused by carers. We know about the chronic forms of that. The interest today is in neglect and emotional abuse. The chronic forms, physical and sexual abuse, are events. They're all part of child victimisation, harm or risk of harm caused to a child caused by others. So the difference is what's caused by carers and what's caused by others. So child maltreatment is within that big circle of child victimisation. And the reason I'm putting these together now is for 3 reasons. First of all, what we know is that they're all harmful. They all require a psychosocial response. If we look at the studies, the follow-up studies, we know that the psychological consequences of victimisation that's not due to the carers can be often just as damaging. The second reason is very often happening to the same children. Although victimisation is very common, children who are maltreated will often, during their life course, be experiencing victimisation, very often. And that's from studies by David Finkelhor in the States and to some extent by the recent NSPCC study by Lorraine Radford here. That's not to say that all victimised children will have been maltreated. That's not the right way around. But maltreatment will often have victimisation as one of the adversities that these children are exposed to. And the third reason is, in our crude administrative data, is often very difficult to distinguish between assault by a carer and assault by a big brother or by a stranger or whatever. And in practice, as clinicians, we often don't really ask those probing questions. Once they get into adolescence, we often don't find out whether it's your dad that hit you or your big brother or whoever. So there's several reasons to put these together. And I'm going to show you some data now that reflects victimisation-related injuries. So we felt comfortable with children aged 10 or under in assuming that assaults there were a manifestation of poor supervision or neglect or physical abuse. In the adolescents, then very much more of victimisation-related injury will be related to peer or sibling or stranger violence, but a fair proportion will still be carers. So here, another cross-country comparison, and this should be published in a few days. This is comparing the incidence rates of population incidence rates in Western Australia with those in England. And what you see is, what you know, is there's a blip in infants. You know, we worry about victimisation-related injuries in infants. Then there's this sort of quiet period for these middle ages, and in fact the incidence rates between 3 and 13 were very, very similar in Western Australia and England. They did not differ significantly. And then we see this steep curve. So when we take the victimisation perspective, we see, as you know, the big problem is in the adolescents. What was interesting here is why were these differences there at the extremes of age between Western Australia and England? These differences here were only in the most deprived centile. And what we infer from that is that there's a particular problem in Western Australia among the Aboriginal community, who are extremely deprived, and where there's a very extreme awareness of problems in that group. So there may have been some awareness recording bias, as well as a big problem with occurrence in that group. This difference here was systematic across all socioeconomic groups and across both genders. And we infer that this may reflect shifting into adult services in England, where there's much less attention to social welfare issues. These children at this age, or these adolescents, will be looked after on surgical wards. They won't be on paediatric wards. And so the chances of them having victimisation and social welfare issues recognised, let alone recorded, are much less. And we think that's what's happening here, but that's an influence. Okay, so that's victimisation, but as we know, over the child life course, one of the other other manifestations of adversity will also be drug or alcohol misuse, self-harm, and mental health as well, although these are the forms that present with injury. So I'm sticking with injury for the moment, and I'm moving into this older age group. We know they're intensely related, and some work that Annie Herbert, who's here in the audience, who's working with me, is doing is really trying to address the question from the England data of whether these are the same children when you look at them over time. This week they came in with an assault. Next week they come in with a overdose. The week after it's drug or alcohol misuse. So our hypothesis is that these are very much the same children, and that there's some degree of sort of chaos in their lives as to what they end up presenting to hospitals with, what the clinicians end up coding them and seeing as the main problem, and what ends up being coded. So the argument here is, it's important, if you really want to understand how this problem is presenting to health services and who needs interventions, all these need psychosocial interventions, then we need to look across all the adversity groups. And when we do that, here's some data from all of admissions to the NHS in England, in Scotland, and Western Australia. You see that they add up to quite a high proportion of injury admissions being related to adversity. So this is just for 17-year-olds. 40 to 50% of these injury admissions that are sitting on surgical wards are related to adversity, require psychosocial responses that probably need to be community-based, long-term, in the community, of what these children, adolescents, are flagging up. And what you see is some variation between what they get labelled. So in England, we have fewer labelled as victimisation compared with Scotland or Western Australia, but more as self-harm. This may be truly that there are these differences, or it may be that there's differences in the awareness of the problems and what they get called. And what they get called may also be related to what services are available. So if you know you've got a drug and alcohol team there, you might call it that, or if you know that you've got a CAMS service that's responsive and will turn up to see these kids, you might call it self-harm. Just to finish off with the spectrum of adversity, I just want to give you some information about deaths, and this is data that will be published tomorrow. This is a 4-country comparison for England, Scotland, Wales and Northern Ireland between 1980 and 2010. The heavy black line is England, and the blue line is Northern Ireland, and the red line is Scotland. So what we've got here is boys and girls, unintentional injuries, so these are accidents, so it's road traffic accidents and accidents in the home. And here we've got intentional injuries, so these are that adversity cluster, injuries due to assault, self-harm, and indeterminate causes. And what you see, the good news is a 50 to 70% reduction across all 4 countries in boys who are always much higher than girls. So that's very good news. England's better than the others. There's significant differences, significantly higher in Scotland and Northern Ireland. But the bad news is that these intentional injuries, this adversity group, has not budged over the last 3 decades. This is the group where we'd expect deaths to be eminently preventable, and there's been no change. And they're forming an increasing proportion of the child deaths, of injury deaths. Okay, I'll just very briefly show you that this is we need to worry about older than the adolescent years. This is showing how mortality blips up in boys. This is data from 2009. These are unintentional accidents. Intentional, this steep cliff edge of deaths as they reach 17, 18, going up 4 times higher in males and females. These troubled adolescents going to young adults will be having their origins of their troubles and probably their presentations to healthcare services during adolescence or even earlier in childhood, when we have the opportunity to intervene before they get really good at killing themselves as young adults. So lastly, to finish off, the healthcare, what can we see about data on services for the family in healthcare? I find this diagram quite useful to just think about the spectrum that we're concerned with. We have harm at the other end, but that will be mediated through harmful parent-child interactions, which are obvious to many health services seeing children and parents together. They will see the issues of mentalisation, awareness of the child's needs, particularly in primary care, and the parent risk factors. So these are areas where healthcare practice can have some impact. Unfortunately, much of our literature has been dominated by the paediatric perspective of forensic input to a judicial response at this far end to do with harm and to do with culpability. We have much less evidence about how health services can be responding to these early manifestations of child maltreatment, particularly neglect, which we know is not has it happened or has it not. It's all part of a spectrum of attention, and it's at what point has it gone on for long enough, bad enough, do we need to intervene? So I'm going to give you two case examples here. One is a whole system look at Central London General Hospital. Here, since 2003, instigated by a very visionary hospital social worker, she trained all staff to recognise children who need safeguarding, but also to ask the adults presenting due to violence, drug or alcohol misuse, or mental health problems, whether they had children at home. And if there were concerns about the children, to notify social services. So here's the data that we looked at from that service, from the database that had been compiled. And this is over 600 cases notified to social care services in 1 year. That's 57 notifications per month to social services from this one hospital. Quite a lot. And what we see is that 40% were triggered by parents. 40% of the notifications. Most of them from parents presenting to A&E with assault, with drug and alcohol abuse, with being in trouble with the police, and about 37% from maternity services. Of the children, most of them were from A&E. Lots of them were not injuries. About half of the admissions only were injuries. What we could also see was relate these to our codes of maltreatment or victimisation concerns. And what we saw that between 1/5 and a half of those who had records indicating concerns were notified to children's social services. So those that get notified are only a half to a fifth of the problem that is recognised. Then lastly, so I've said something about medical, in my pyramid, I've said something about medical presentations. I think there is a much bigger issue here that we've not managed to measure very well. And those of you that are practitioners will know that the people that you really worry about are the children with often chronic conditions on the wards, with parents with poor parenting capacity, and the likelihood of neglecting those children. But for the last few minutes, I'm going to focus on primary care and family services. So these are data from Jenny Woodman, who's just finishing her PhD on this work. And this is for 1.5 million children in the UK. This is one of the big primary care databases that covers 5 or 6% of the population. And what we did was, together with GPs, developed a cluster of codes in these data that could pick up concerns about child maltreatment. And we showed, that Jenny showed, that there was an increasing prevalence of these codes over the years. Now that may just reflect that GPs are getting good at coding things rather than just putting it in text, which is harder to search. And by 2010, 0.8% of children had, in any 1 year, had some form of child maltreatment concern in their GP records. So not much variation between practices, so this shows that GPs are picking them up. And if we go back to that pyramid of infants that I showed you early on, so just the infants, where only 500 maltreatment-related injuries have been notified, this is about 10,000 infants across England, because it's a bit higher. It was 1.5% of infants, 0.8% for children overall. So they are picking up stuff and they are coding it, but still under-recording. So if we can compare this to what we'd expect, then we know from the self-report and parent report studies that we'd expect about 4 to 10% maltreatment occurrences per year. In the past year, we're picking up only 0.8%. We'd expect 0.4% to have a child protection plan. In the GP records, only 0.2%. We'd expect around 5 to 6% to be referred to social services. GPs are only recording 0.1%, but maybe they don't know about a lot of it as well. She's also done some qualitative research, which is not published yet, and the difference was striking. What we saw was that the GPs recorded hard outcomes, such as physical abuse. Remember, GP records can be seen by the parents and the child can see them when they're 18. So you have to be very careful about what you put in GP records. What they discussed in 11 practices in qualitative interviews was emotional abuse and neglect. These were the families that were keeping them awake at night, that they were doing a lot of work with, who they were recognising and managing through knowing and supporting parents. And so there's an indication of that issue from some work in Denmark, but this is really showing that work through the parents to support the children is seen as the way for GPs, and they weren't labelling it as child maltreatment or neglect. They were not using those words. In fact, they recognise these patients. These are their heart sink patients. These are the early signs of their heart sink patients. So just to sum up, the way forward for health services, we need to respond to the varied manifestations of child maltreatment and its consequences across the whole child life course. We will miss parts of the picture if we close in too narrow. We need to look across the whole system for parents and for children. And for this, primary care is the family health service. It's at the core. And it's at the core, not of just the family, but at the core of titration of interventions. You might not get it right first time. They may need CAMS this year. They may need something else next year, and so on. Who is there in the community that has that continuity of care, that can monitor and monitor their interventions from different areas? It's primary care. But most of all, we don't know what to do. We need effective community-based therapeutic responses for parents and children, and as you're going to hear later today, there's much more research to be done in that area. So thank you very much. I'd just like to thank my collaborators and funders.
Thank you very much, Ruth, for taking us through from a health perspective, both a national and international perspective, looking at the importance of what the contribution of health professionals that might make in identifying and thinking about how to respond better, probably would be the best way of putting it in terms of intervention. We have a few moments for questions, so somebody got a microphone? Yeah, who's got the microphone? Anybody like to ask anything of Ruth at this point in time? Just put your hand up, Bill will come and find you.
Thank you, Ruth. I'm really interested in you saying about a lot of GPs are kind of taking it onto themselves to work with those families. Did you feel from research that they should actually be reporting it more to social care, or do you think it's right that they're kind of working with the families themselves in-house?
Very good question. I think we have to, some of them would have been reported to social care, but social care in a child life course is an intervention that's on average a year or less. And the GP is the person that's with that family, and that child over very many years. So even those that are notified at some point to Children's Social Services, they will need to be managed by the GP during that time and in between times. So there's a very important role for GPs. I think we also have to look at what is the evidence of what works. So we know from the common elements work that's been done on social care interventions that one of the core elements that's really important is a therapeutic relationship, and the second thing was tailored responses to the individual family needs. We also know from all the work at the more extreme end, multisystemic therapy with delinquents and then with child maltreatment, that you have to address the needs of the family, of the parents, if you're going to do anything about the child. So I think you have to have a service there that is addressing their needs as well as the children's needs, and that is looking at a therapeutic response. Now, in many instances, for a time, social care will be the team that steps in to address certain needs. At another point, it may be CAMS. At another point, it may be early education or whatever. But you need to have some overarching continuity with a therapeutic relationship at its heart.
Does the pressure on GPs kind of rise and their numbers get higher? Do you think that's still realistic? My experience, because I've just come from hospital sector, is that GPs aren't having the time anymore to do that very important role. And I just wonder how the pressure on GPs will impact on that.
No, I think you're raising a very real problem. It's that there are enormous pressures, and they've also, for a long time, been caught in a catch-22, where they can't say what they're doing because they will they run the risk of being held up for disciplinary proceedings, or at least castigated by social services for not referring the cases they're managing. So there's been this cycle of problems where you can't call it what it is, because otherwise you're in trouble. So I think, what I'm trying to do here is to say, let's open it up, let's recognise what is going on and try to make it better. I have to, the caveat is that these were 11 practices with an interest in, one of the GPs in those practices had a special interest in child protection. So, they're not going to be representative of all general practices, and I recognise there are enormous problems. But what I also see is that further fragmentation and bolt-on of other services is not going to help. And I think we need to perhaps look more to the Scottish model, if you like, where you're looking at better coordination of existing services rather than the model that we've gone down to some extent, which is separate services.